I'm Junyoung Song. I'm an adult infectious disease specialist. In my presentation today, I'll talk about clinical spectrum and infection control of COVID-19 in South Korea. The first part is clinical spectrum of COVID-19, and then the infection control measures for COVID-19 will be presented at the level of each hospital and government of South Korea. Coronavirus is classified into four genus of alpha, beta, delta, and gamma. Among them, alpha and beta coronaviruses can cause human infection. Contrary to these common cold coronaviruses, three beta-derived coronaviruses such as SARS-CoV, MERS, and SARS-CoV-2 might cause severe infections, including pneumonia. SARS-CoV-2 is believed to have originated from the Hunan market in Wuhan, China. It's been presumed that the virus was transmitted to humans in the process of slaughtering a wild pangolin. SARS-CoV-2 is a small single-stranded RNA virus, similar in size to the influenza virus, and the virus is very prone to genetic mutation. SARS-CoV-2 binds to the ACE2 receptor by spike proteins on the surface of the viruses. Because ACE2 is distributed at highest density in the upper respiratory tract, the virus can be easily transmitted through respiratory droplets. And since ACE2 is distributed in heart, blood vessel, and kidney also, disseminated SARS-CoV-2 infection can develop in severe cases. Most COVID-19 cases were thought to have fever and respiratory symptoms, but according to a study that analyzed 3,000 Korean domestic compound cases, only 30 to 40% showed fever and characteristic respiratory symptoms. After 5-day incubation periods on average, diverse symptoms may develop. Initially, most of them are mild, but 30 to 40% have pneumonia, and some of them are rapidly worsen around 10 days. So, 14% require intensive care treatment and 5% are fatal. Therefore, even if the initial symptoms are mild, the elderly and chronically ill patients should be closely monitored for the possible aggravation during treatment. Looking at the pathogenesis of SARS-CoV-2 infection, in addition to the direct cytotoxic effect by SARS-CoV-2 virus, renin-angiotensin-aldosterone system, RAS dysregulation by ACE2 receptor depletion, SARS-CoV-2 virus-induced endothelial cell damage related thromboinflammation, and immune dysregulation are three main mechanisms for this progression by SARS-CoV-2 virus infection. One of the serious pulmonary complications seen in patients with COVID-19 is microclot, which causes thromboinflammation of lung microvessels. Clinical hypoxia is rather severe compared to the severity of pneumonia or pulmonary edema on chest X-ray, but pulmonary embolism is not seen on chest CT. Microclot is such an atypical ARDS type complication. Pulmonary endothelial damage and inflammation can cause multiple microvascular thrombosis of alveolar septal capillary, and pulsation defects can be confirmed on lung scans. For this reason, low molecular heparin is prophylactically used in the treatment of severe COVID-19 cases. Renal complications have also been reported in patients with COVID-19. SARS-CoV-2 virus can infect kidney proximal tubular cells with ACE2 receptors, so proteinuria and hematuria are very common renal manifestations. In particular, 20 or 40% of severe COVID-19 patients in the ICU are reported to develop acute renal failure within 1 or 2 weeks after hospitalization. Several factors are complexly involved in acute kidney injury in COVID-19 patients. The direct cytotoxic effect of SARS-CoV-2 virus on tubular epithelial cells and Indirect factors such as RAS dysregulation, thromboinflammation, immune dysregulation, and rhabdomyolysis might contribute to the development of renal failure. Similar to renal complications, cardiovascular complications are caused by a combination of direct myocardial infection, immune dysregulation, and hemodynamic failure. Specifically, severe COVID-19 cases can be complicated by ischemic heart disease, arrhythmia, or heart failure with a 2-week interval from hospitalization. Looking at the current situation of COVID-19 pandemic in South Korea, most cases occurred in the age between 20s and 50s with high social activities, but 95% of the fatal cases were concentrated in the elderly, aged over 60 years. The overall fatality rate is estimated about 1.7%, much lower than the global average of 3%. This is case fatality data from the initial 4-month periods of COVID-19 pandemic. Compared to South Korea, Italy and China showed significantly higher case fatality rate, up to 6 times. Italy has the highest case fatality rate because the elder population is larger than Korea, and infection occurred mainly in the elder people. In China, the young age population is higher than that of Korea, but the COVID-19 cases were concentrated in the elder population as shown here. In addition to old age, chronic medical conditions are known as important risk factors for severe COVID-19. SARS or MERS has a high infection and fatality rate in healthy adults, whereas most fatal COVID-19 cases occurred in the elderly and chronically ill patients, similar to influenza. According to the early Chinese report, compared to healthy adults, the case fatality rate of COVID-19 was 9 times higher for diabetic patients, 13-fold higher for patients with cardiovascular disease, and 7-fold higher for patients with chronic lung diseases. In summary, SARS-CoV-2 receptor ACE2 is widely distributed in human bodies across respiratory tract, heart, blood vessel, kidney, and intestine. In the development of severe COVID-19, RAS dysregulation, immune dysregulation, and thromboinflammation are 3 important mechanisms. The case fatal rate of COVID-19 is thought to be about 2%, but the fatal rate is much higher in the elderly and chronically ill patients. Therefore, it is very important to block the transmission of COVID-19 to high-risk groups, as can be seen from the contrasting results between South Korea and Italy. Now let's move on to the infection control strategies for COVID-19. 20 to 30% of COVID-19 cases are asymptomatic, and even in the symptomatic cases, the symptom onset is insidious, and the initial symptoms are very mild. However, they are highly contagious even at the early stage of infection. And moreover, unlike other respiratory viruses, the viral load of SARS-CoV-2 is very high in saliva during the early stage of infection, so the virus can easily spread out during conversation or eating together. Actually, there have been many cases of COVID-19 after brief conversation or eating. In the paper published in NEJM in July, SARS-CoV-2 RT-PCR and viral culture were conducted serially over time before and after symptom onset. Interestingly, asymptomatic patients released high concentration of viruses, and pre-symptomatic patients also released high concentration of viruses even 3 days prior to symptom onset. Therefore, the contact tracing was expanded to 2 or 3 days before the symptom onset. Even though SARS-CoV-2 gene fragments are detected for a long period, more than 3 weeks, on PCR tests, a viral virus is not cultured if more than 10 days have passed from symptom onset. The red circle means viable virus detection. After 10 days from symptom onset, viable virus was not detected anymore. MERS and COVID-19 is known to have similar incubation periods, about 5 or 6 days. However, there are significant differences in the viral shedding pattern and transmission dynamics. In case of MERS, viral shedding reaches a maximum level on the 7th day from symptom onset. At that time, the patient is the most contagious. In comparison, SARS-CoV-2 infection is already the most contagious at the time of symptom onset, making it very difficult to block the spread of COVID-19. SARS-CoV-2 has a high R-naught value of 2.5, which means high transmissible potential in the community. Compared to other novel viruses, SARS-CoV-2 has a shorter generation time and high cellular viral load, so it is very easy to spread during conversation and eating. In addition, symptom onset is ambiguous and all symptoms are mild. This is why patients unintentionally spread the virus to contact persons. Recently, many nosocomial COVID-19 cases occurred in a teaching hospital in the southern part of South Korea, causing the hospital to be closed and medical system was collapsed. Similar cases have been reported in many other countries as well, so it is very important to keep hospitals safe and to do their functions. During early COVID-19 pandemic, Korean government and each hospital made hospital preparedness plans. In the hospital level, education and training, universal mask wearing, inpatient monitoring were reinforced. Many hospitals in South Korea has been conducted a SARS-CoV-2 RT-PCR test for all inpatients irrespective of symptoms before admission. Like other hospitals in South Korea, we regularly educated medical staffs about infection control strategies and personal protective equipment, and made it mandatory to wear face masks inside the hospital. Hand hygiene and mask wearing are important for each patient or medical staff. There is no study conducted on COVID-19, but according to a study conducted on influenza viruses of a similar particle size, hand hygiene alone was able to prevent influenza infection by 26 to 38%. Moreover, mask wearing showed a statistically significant prevention against influenza-like illness with 66% effectiveness. Although a well-designed study has not been conducted on COVID-19, the effectiveness of mask wearing can be confirmed indirectly through a reduction in the incidence of COVID-19 after the introduction of mask wearing. Indeed, in New York City, since the introduction of mandated mask wearing, it's shown a dramatic decrease in COVID-19 cases, unlike other regions of the United States. Environment control is also important because COVID-19 can spread through contaminated environments and formats. Since SARS-CoV-2 can survive for 4 hours in air, 24 hours on cardboard, 3 days on stainless or plastic material, and 4 days on glass material, ventilation and environment cleaning is important. It should be thoroughly disinfected by rubbing with an environment disinfectant with sodium hypochlorite or quaternary ammonium complex compounds. Based on the past experience of MERS epidemic in 2005, Korean government established several safe hospital strategies. First, hospital entrance was restricted and gate screening was strengthened. Second, 2 specialized clinics were operated at the outside of the main hospital building, one for patients with epidemiologic linkage with COVID-19 and another for febrile respiratory patients without epidemiologic linkage. In addition, pneumonia patients were preemptively isolated until negative confirmation of SARS-CoV-2 RT-PCR. As for the patients in the area of COVID-19 outbreak, telemedicine was introduced. As you can see, the body temperature at the entrance is checked with a fever detector, and febrile symptoms, respiratory symptoms, and contact history with COVID-19 patients are investigated using a smart device or a paper questionnaire. If fever, respiratory symptoms, or contact history with a COVID-19 patient is identified, the screening process. The patient will be treated at a fever respiratory clinic or COVID-19 clinic, and SARS-CoV-2 RT-PCR will be taken. I'm gonna summarize now. Some clinical manifestations, short generation time, and high salivary viral load are challenging problems in the infection control of COVID-19. Most South Korean hospitals have been operated safely without nosocomial outbreak. Universal masking, gate screening, specialized clinics, and preemptive isolation of pneumonia patients are important factors of successful infection control in South Korea. Thank you for your attention.